The August MEC Minute is going to be on traumatic brain injury or TBI. Now, this is something we've talked about in bits and pieces in the past, but I thought I'd throw it together as a kind of a short review of TBI, at least as it results or how it represents a problem for us to manage in the field. So what are we going to do? We're going to talk about what is a TBI and review some basic statistics. We could talk about mechanism of injury and basic statistics, economic costs, probably for 15 or 20 minutes, but I'm not going to do that. Just a brief introduction. We're going to talk about those things, those interventions that we provide or should provide in the field that prevent a worsening of TBI. So particularly what things will make TBI worse if we don't act appropriately. And I'll talk more about the 3H bombs, which I know we've talked about before. We're going to review some best EMS practices in managing TBI. A lot of it has to do with the 3H bombs, which is hypoxia, hypotension, and hyperventilation. And we're also going to talk a little bit about TXA and its value for managing TBI. And I got a slide or two to talk about that. So when we talk about TBI, we often think about these massive, devastating head injuries like the epidural hematoma on the left or the gunshot wound to the head in the middle or the subdural hematoma on the right. But TBI is a spectrum of injury, and it's an injury secondary to a forceful blow to the head or piercing of the head by an object like a bullet. And it's really a continuum. It's not something that's, 1, 2, 3, 4, 5. It's always somewhere in between. And we could classify TBI based upon multiple criteria. And again, it's a continuum. There's mild to severe, and there's mild from which the patient will recover. There's mild that may have some ongoing impediments for several weeks, or it could be severe where their patient's life is in danger. But if we look at it, we can use structural imaging to evaluate. And, in mild TBI, the imaging is normal. Moderate, severe head injuries, so it could start out as normal or mildly abnormal or normal at first image and then show worsening with time, depending on how quickly the patient gets to the CT suite. If we look at duration of loss of consciousness, mild tends to be loss of consciousness of 30 minutes or less. Moderate is more than 30 minutes, less than 24 hours. And severe head injuries are unconscious for more than 24 hours. And some of those unfortunate patients are unconscious and do not wake up. We can think about alteration of level of consciousness or mental state. Mild can be altered up to 24 hours, and moderate and severe really is based on other criteria. So if you think about somebody who's been concussed, they're a little confused, they're repetitive, they keep asking the same questions over and over again, that's a mild head injury, but typically those symptoms will clear within 24 hours. Whereas if symptoms go on, they're repetitive, they're amnestic, they don't remember anything that happened, they can go on for a while. And again, we talk about post-traumatic amnesia, the patient does not remember what happens. Typically the mild brain injuries recover within the first day and they start to remember things, whereas moderate is between 1 and 7 days, and over 7 days is severe. But the thing for us probably as EMS providers is, since we have short scene times, is what's the patient's best Glasgow Coma scale? And when we talk about some things in future slides, I think it's going to be, this Glasgow Coma scale is going to help us make clinical decisions. So, typically mild head injuries have a GCS of 13 to 15, which is the best score in the first 24 hours. For us, we're going to say, what is their GCS when we get there? Moderate's going to have a GCS of 9 to 12, and then severe is less than 9. Many of us in the world of emergency medicine think that any patient with a GCS of less than 9 probably is going to need an artificial airway like intubation, at least during those first hours to days of care. But I think we need to focus on what's the patient's level of consciousness and what is their Glasgow Coma scale, because we may make some therapeutic interventions, particularly related to TXA, based on the GCS. So keeping it simple, mild TBI is a concussion. Somebody got hit in the head. They had a transient altered level of consciousness. They may be a little confused, but all in all, their GCS is 13 to 15. Moderate for us is going to be GCS of 9 to 12, and severe TBI is going to be GCS less than 9. So that's what we need to focus on. Every patient with an injury, every traumatic complaint whether it's an ankle injury or a head injury, should have a GCS documented on the run report. And to my knowledge, we've got that as a hard stop on all of our injury-related complaints, so that if you have to do your run report, you've got to enter a GCS. So how about the burden of disease? What does traumatic brain injury do to us, both economically and socially? So I'm using the best data I could find. A lot of the data is through the CDC. They have a large database regarding head injuries. And in 2019, head injuries resulted in over 220,000 hospitalizations. And in 2021, almost 70,000 deaths directly related to TBI. Head injuries are involved with about a third of the patients who have trauma and die from traumatic injuries. Patients age 75 and up account for about 32% of the hospitalizations and 28% of the deaths for TBI, but only represent about 14.5% of the patient population, or the nation's population in the United States. So, the geriatric patients, so 75 and up, have a disproportionate frequency of hospitalizations and deaths related to head injuries. Part of that's because of their mechanism of injury. Part of it is because they have increased fragility, and many of them are anticoagulated or on antiplatelet medications. If you look at the group as a whole, males account for twice as many TBI patients as females, and males are 3 more times likely to die. I think that's as much related to they're more likely to engage in dangerous activities, and those dangerous activities they are involved with tend to be at higher risk. So I don't think it's all a genetic predisposition. I think it's just as much the type of activities male patients will be involved with. And if you look at the direct medical cost for managing patients with TBI injuries in the United States, the direct cost of care is over $60 billion a year just for traumatic brain injury. This number is only related to medical care. I tried to find some numbers regarding the total economic cost of a brain injured patient. Could not find great numbers, but it seems like a cost of care for someone with a severe brain injury can exceed $150,000 a year after their initial injury, and cost of care for those who survive. And TBI patients could, in their lifetime, cost over $4 million to care for. So that's how much it costs to care for them, and it doesn't have anything to do with what their earning potential is that's been lost by having the head injury. So as you see, the economic cost to us as a society and to each patient individually for a TBI is huge. Regarding mortality rates, if you look at it, again, it looks, as we get older, the risk of death, number of deaths per 100,000 people goes up. So if you're taking your average 20-year-old, you're probably looking at about a 15% or 15 deaths per 100,000, where if you look at the geriatric population, it's more like 76. And if you look at the geriatric population, particularly those 75 and up, about 2/3 of those head injuries are secondary to falls. We know that. We see patients who trip and fall. It's the throw rugs. It's the cat between the ankles. It's somebody who loses their balance because they stood up quickly. We know that the elderly suffer a significant number of falls, often related to head injuries. And if you look at those who die from head injuries, 2/3 of those deaths are directly related to a fall. How about predictors of poor outcome for patients we see in the field? So there have been some very good studies on this. The best studies have been the EPIC studies out of Arizona, where they looked at TBIs and the risk of death across the state utilizing their state EMS database. It was published by about 8 to 10 years ago. Very well done. And a lot of what I'm going to talk about from this slide forward is going to be based on the information coming out of Arizona. But there are 3 indicators of poor outcome, the 3 H bombs, all for hypoxia, hypotension, and hyperventilation, that are directly related to increasing the risk of death. So any episode of hypoxia, O2 saturation less than 90, in the pre-hospital arena before the patient arrives at the hospital independently is associated with doubling the patient mortality. So if I have a head injury and my PO2 for EMS is always over 90 versus my PO2 at any point during the time I was under EMS care is less than 90. If my PO2 is less than 90, my likelihood of dying from the same injury doubles. If you had talking about blood pressure, any episode of hypotension where the systolic blood pressure is less than 90 at any point during the course of care provided by EMS doubles my risk of dying. Now we have to be careful because, for our trauma protocol, we say we want to allow permissive hypotension. If the patient has ongoing bleeding, we're okay with their blood pressure running a little low. We call that permissive hypotension. That directly contradicts what we've seen for head injury. So if we have a patient with a significant head injury, we are less likely to allow that patient to be hypotensive. Our goal should really be to keep that systolic blood pressure at least 100, if not higher, because of that head injury. So it's a conflict there in our treatment priorities. Do we allow the patient to run a little low on their blood pressure because they may be bleeding out, or they've got a massive head injury or significant head injury? Should we try to get their pressure up to at least to 100? Some of the more recent information that came out of Arizona is we've yet to identify an ideal systolic blood pressure. So we know that 100 is better than 90, 110 is better than 100, but there's no perfect level that if you hit this range, whether it's 110 or 120, the patient's likelihood of survival is going to be unchanged. So that should be our target. For now, our target is to keep the systolic pressure over 100 if there's a significant head injury. And then any episode of hyperventilation, that's something we are responsible for. Any episode of hyperventilation also is independently associated with a doubling of mortality. So if that patient requires an artificial airway, we put it in an I-gel, we put it in an endotracheal tube. Our goal is to monitor our ventilations and to avoid hyperventilation. Our goal is for a PCO2 of 35 to 40. If you take all three of these characteristics, somebody who has a period of hypoxia, hypotension, and is hyperventilated by EMS, their risk of death is 6 times greater than if they had this same injury without these episodes of hypoxia, hypotension, and hyperventilation. So be careful what we do. And this is why we're going to talk about what should we do for patients with head injuries. So for us, sorry guys, I got a little aggressive with the button. Any loss of consciousness. So anybody who's out for a few seconds or who doesn't remember the event, anybody who keeps repetitive questioning or perseverating, patients say, what happened? You tell them what happened. 2 minutes later, what happened? You tell them again. It goes on and on. Okay. So what happened to me? What happened to me? What happened to me? So any loss of consciousness, any perseverating, those patients are TBI patients to be followed and treated per our protocols. Any altered level of consciousness, but keep in mind, GCS of 15 does not exclude a major TBI. Hence my picture of the epidural hematoma on the right. The epidural hematomas, they have a head injury. They may have a transient loss of consciousness. Now they're back awake and alert. And as this hematoma expands, they begin to lose consciousness again. So a GCS of 15 doesn't necessarily mean the patient's not had a major injury. And then any seizure related to the fall is an indicator the patient has a TBI. So if the patient falls, hits their head, then has a seizure, we consider them to be a TBI patient, even if they're now awake and alert. The exception there would be if the patient has a history of seizure, they had a seizure, it was witnessed seizure, they had a seizure, fell down, hit their head. I would be careful about the head injury, but I wouldn't necessarily say they're automatically a TBI patient. So what are we going to do? Well, I talked about oxygen is important. We want to avoid hypoxia. So, we want to follow A, B, C, Ds, and O2. So, follow your A, B, Cs, and Ds, but think about getting them started on high flow oxygen immediately. I know in the past we've had conversations about avoiding hyperoxia, avoiding giving oxygen to patients who do not need it. But if we're talking about patients with a head injury, It's been shown that if all of them got high flow oxygen, we're avoiding hypoxia and we're going to have a better outcome with the patient. This was shown to be effective in Arizona. We want to support ventilation as needed, but same token, we do not want to hyperventilate the patient. So we want to go for that target end tidal of 35 to 40. And that this means probably if you bag the patients every 6 seconds, ventilate the patient every 6 seconds, you're going to be okay. And just pinch the bag. Don't use the entire volume of the bag. Put capnography on the patient and monitor their CO2. Keep in mind that in the state of Ohio now, there's a requirement that if you have an artificial airway in place, such as an iGel or an endotracheal tube, or have the patient on CPAP or BiPAP, that patient is on continuous waveform capnography. So this is in line with the state's mandate. Think about getting that IV started early. If the patient has any altered level of consciousness or any risk of multi-system trauma, you never know. The patient may have had a splenic injury and they start to bleed, and then they become symptomatic 20 minutes after the accident. They've gone from having normal vital signs to clinically deteriorating. You need that IV in order to give a fluid bolus or whatever is necessary to keep their systolic blood pressure over 100. And then pre-treat to prevent hypoxia and hypotension. Again, high flow oxygen, whatever fluids are needed to sustain an adequate blood pressure of 100 or better, 100 millibars mercury or better. Those simple interventions buy time for the brain that's injured. Now, I also realize that we don't operate simply in single system injuries here. Patients could have multiple trauma other places. You need to take care of other things such as controlled bleeding, but you always have to think about maintaining adequate blood pressure and adequate ventilations, adequate oxygenation for your patients. So there's no such thing as too much O2. Good BLS care is critical. Most of what we talked about in terms of managing TBI patients in the field are simple, straightforward treatment protocols. Don't require a lot of sophisticated medications unless you have to intubate the patient. Monitor early and repeatedly watch the blood pressure and pulse ox. If the blood pressure is fine when you arrive on scene and the patient has significant injuries, get vital signs every 5 to 10 minutes during the course of care and transport. I know we often get into the rut of we do one set of blood pressure and pulse rate, and if it's okay, we leave it there and we don't repeat it. Automate the machine, have it cycle every 5 minutes, whatever you need to do to repeat your vital signs to make sure the patient does okay. Monitor end tidal CO2, particularly if you have to use a BVM or any type of an advanced airway. We have to consider the risks of intubation or use of iGel in order to augment ventilations. Think about whether you need a tube or not. If the patient needs to have a secured airway because they can't keep their tongue out of their way, that makes sense. But expect and understand that your medications and the process of intubating the patient may result in transient hypoxia or transient hypotension, neither of which is good. Remember, any episode of hypoxia, any episode of hypotension during the course of your care is going to double the patient's risk of dying from their head injury. And then treat hypotension or impending hypotension. Try to keep that blood pressure over 100. I know we'll keep haranguing about ventilation, but we are responsible for ventilating the patient. Think about those adjuncts that can help you ventilate the patient appropriate. We can get the bags, the BVMs that have the rate timer so it flashes when the light's on, you ventilate. Think about flow control bags where you can only ventilate or force so much air at a time. And then think about lower volume bags. I know we've had a couple of emergency departments express concern because EMS brings in a cardiac arrest patient and they've got a pediatric ventilator or a pediatric bag on the patient. Well, pediatric bag is perfect if you're going to try to give the patient the entire volume of the bag. It avoids hyperventilation. Think about having somebody as a spotter to be the ventilation EMT, somebody to keep track of the patient's ventilations. If you're working in an austere environment, you've got 2 or 3 providers on scene, you may not be able to have somebody do just that, but think about it if you can. And think about if and when your patient needs an artificial airway. Because you can do it doesn't necessarily mean you should. So we need to meticulously manage patients' ventilation to avoid hyperventilating the patient, which again results in worse outcome. In some cases, if you don't do it well, your ALS airway, it could actually be worse for the patient if you just bag them to the hospital. You have to make that call in the field, but you need to understand the risks for the patient if you like to go the path of intubation. If you have a significant head injury, that might be the opportunity or the time for your best airway person to manage the airway and intubate the patient. Well, how about PD cases? How about pediatrics? Really, some of the parameters we want to use may be a little different, but we have a similar approach to the patient. So our vital signs and target volumes may be a little bit different, but we still need to monitor that patient closely to catch early deterioration. So in peds, airway management can be more difficult. Consider the basic maneuvers to get the patient to the hospital rather than the more advanced maneuvers. Each of us does not do a lot of pediatric intubations. The airways can be different. And in a high stress situation, you may be better off bagging that patient to get them to the hospital. Think about the supraglottic or endotracheal tube only if your basic efforts fail, and consider other options or consider intubation and so on if you have a high aspiration risk or if you've got a long transport time. If we're talking about what parameters are we going to look for, well, for an infant, meaning less than 2 years of age, our blood pressure goal instead of 100 is going to be 70 or better, and we're going to breathe that child at about 25 breaths per minute. If we're talking about a child up to age 14, our goal blood pressure, systolic blood pressure, is over 80 millimeters of mercury, and our bag rate will be about 20 breaths per minute. And then a child who's 10 and up, or even 14 and up, we're going to go more toward the adult goal of 90 to 100 millimeters of mercury, and we're going to bag that patient about 10 times per minute. And we're still going to watch the end-tidal CO2. We're still going to treat the patient with high flow oxygen to maintain a good oxygen level to help save the brain. So one of the things we've talked about is, what about TXA? So we have TXA in our trucks. We use it for penetrating trauma. We use it for trauma where the patient bleeds out onto the street. But does TXA have benefit in head injury patients? If you look at the crash study, which was one of the original studies, TXA did not seem to make a difference in outcome, but in terms of outcome for patients with head injuries, but it was shown to make a difference for patients with acute blood loss resulting in hypotension. However, they went back and redid the data and took another look. And if you look at all the patients with head injuries, the data says TXA offers no benefit. However, if you take out the patients who already have severe head injury, where the outcome is expected to be poor, so you take out those massive head injuries and you look at the patients with mild to moderate TBI, if TXA was given to those patients, there's a 20% reduction in deaths. That is significant. So the bottom line is, TXA does not help those with severe TBI. What is done is done. It's too late for us. However, for those patients with mild to moderate TBI, it reduces the risk of death and it keeps bad things from getting worse. And this study also seemed to show that TXA does not appear to increase risk for MI, pulmonary embolism, or DVT. So if we think about it, we need to consider using TXA in patients who have at least moderate severity of injury. So from my perspective, if a patient has a GCS of 9 to 12, they should be considered a candidate for TXA. So in summary, TBI is a major cause of death and disability in the United States. It has a huge economic effect on us, not just in terms of medical care, but the cost of earnings potential for the patient and the cost for ongoing care when the patient's being cared for as disabled. Older patients are at greater risk of death and disability. The 3 H bombs kill patients: hypoxia, hyperventilation, and hypotension. And what we do in the field will affect patients' outcomes. So keep that in mind. Treat hypoxia. Everyone should get high flow oxygen. You're at a football game, somebody gets their bell rung on the field. Our goal should to start them on high flow oxygen. Get things started early. it's been shown that high flow oxygen for patients with head injury results in better outcomes. Treat hypotension. Our goal systolic blood pressure should be 100 millimeters of mercury or better. I know it conflicts with our goal of permissive hypotension. It's a balancing act. If we don't preserve the brain, it doesn't matter how much of the rest of the body we save. So we have to try to get that blood pressure up. Avoid hyperventilation. So if the patient has an artificial airway in, whether it's an iGel or an endotracheal tube, well, our goal PCO2 is 35 to 40. And finally, if you have a patient with moderate TBI, those with a GCS of 9 to 12, consider TXA. It's been shown to be safe and effective, and it reduces risk of death by 20%. If the patient has mild head injury, I would have probably not start TXA. If the patient has massive head injury, TXA is not going to make a difference. So keep that in mind as you approach your head injury patient. So that's what I have for TBI. Like I said, I could go on and talk about the economic costs and so on, but I wanted to cover those essentials that I thought you needed to know so you can provide care for TBI patients in the field. If you have any questions, please post your comments or on Basecamp or send me an email via this email address. Thank you.